Okay, got it. Hello, how are you?
Very well, and you?
Okay, can you hear me?
Yes, clearly.
Yes. So, this patient is first leg main case for me. Is last leg main bifurcation. The case at this TCTAP session for me.
Okay.
I show the three previous different cases. One is 101, the relatively simple distal bifurcation. I performed the crush technique. Second was 111, diffuse distal bifurcation. I performed the crush technique. And the third one is severe calcification, confined distal and main, osteum and LAD. I performed also crush technique.
Okay.
Already showed the three crush technique. I'm going to show some different technique.
Okay, Dr.
So,
Wong.
yes.
All right, so before you start, as we really have very distinguished panel here. All right, so I want to just Dr. Akasaka, Joo-Jim Hu, and Jung Song, Gu Bongwon, Dr. Onuma here, Pal Merini, Dr. Chui, Dr. Urban here, right? So
Yes.
thank you for joining us. Dr. Chen Wu is here.
Yes.
All right.
Yes, so, and I introduced our team, and my right is, she is our previous fellow. Now, Gyung-Min Park is a professor in the Ulsan University of Hospital, and Dr. Jo he is a senior fellow, and the Dr. Zhang he is the chief technician. So, Professor Park, could you explain patient background?
Our patient is 63 years old female, and her the clinical manifestation was the stable angina, and risk factor was the hypertension. About 2 years ago, she underwent PCI at left main to the fractional LAD with a giants 3 millimeter by the 28 millimeter, and CAG showed the severe stenosis, circumflex ostium. Next. Her clinical risk factor was the hypertension. Next. And echocardiography showed the normal LV systolic function without regional wall motion abnormality, and the treadmill test showed the positive the test at stage 3, and thalamic spec showed the large defect at circumflex territory. And syntax score was 12 point, and we already checked the angiogram,
Yes.
and we also checked the FFR. The right coronary artery is the FFR was 0.86, and mid LAD was 0.81. Next. So now our target was the circumflex ostium.
So, and if I'm going to summarize, 63 years relatively young female, and 2 years ago, she underwent provisional stenting, proximate to leg main ostium was covered using giant stent. And a couple of months ago, she complained recurrent chest pain, and the treadmill test was absolutely positive. Thalamic scan was absolutely positive for sulcal territory. This is area coral view. Initially the guiding catheter insertion is very difficult. The jockeying catheter doesn't match. It's finally we select XP guiding catheter 3.0. This is area coral view. You can see there is some disease. Next one. This is the 2-wire was past that region, and there is some very tight sulcal region. Next one. Looking at the spiral view, much ugly shape, and you can see definitely very, very tight severe stenosis of sulcal ostium. The previous main stent relatively is okay. So that is our patient brief presentation. People showing the IBUS I'm going to hear some opinion about the panel and discussion.
One of the questions regarding the previous PCI is circumflex osteo has been fenestrated from left main to osteo, or you never touch that osteo of circumflex.
Yeah, right.
So proximal
It's been dilated or not?
LAD main stent is just a crossover.
Yeah, right.
Without
Just crossover.
fenestrate.
Without any touch of the sulcal ostium. At the time, sulcal ostium is relatively okay.
So, Dr. Bak, can you remember I was finding a before the intervention of Circos, was it disease-free or
Yes,
some disease?
there is a slightly mild stenosis, diameter stenosis, 20-30%, but not severe much like here.
Yeah.
And there was some much progression of sarcosteum.
So, would you show us IBUS?
Okay, got it. As initially we do IBUS from LAD to the main. Okay, this is the distal LAD stent, and the stent relatively okay. There is a mild intimal hyperplasia. Okay. 자, 조금 빨리. Okay, this is looking at the sarcosteum is coming. It's 11 o'clock.
Yeah.
Yes, we don't know how much stenotic that region, and this is a left main. There's a slight calcium. Is looking at the left main ostium. Is a stent was nearly totally covered the up to left main ostium. So, and the next view. Initially, the first wire passed on the beneath of the stent strut. Is okay. Next one. Is IBUS does not pass, so that was a previous sock is beneath of the stent strut. Is IBUS does not pass. At this point, is I tried to additional the wire, and next one. This is a additional wire insertion step. Okay, this is a additional wire. It's make a band the U shape, bending, and then next one. And then U-shape bending, and then we're gonna recross that region. It's take some time. Okay, so fortunately, past that region, the sarcosteum. Okay, got it.
Yeah.
And then we're gonna check the IBUS for sarc region. Okay, can you show us? Okay, this is a native valve. Could you show us area coral view?
Big vessel?
Yeah, big
Real
vessel,
at the wrist.
3.5. Yeah,
Calcification.
area coral view. Yeah, okay. This is some calcification. It's a
Mineral
plaque sock. And then you can see how much severe stenosis of the sarcosteum.
Very severe.
Yeah, and then the plaque is circumferential. This is nearly not yet. Okay.
3.5.
3.5. Okay, so added ostium is coming. Okay, here is the most stenotic part. Is plaque was the almost the full circumferential plaque.
Okay, fortunately, mainly fibrous plaque, right?
Definitely.
Solved
Yeah,
by
yeah.
IBUS.
Yeah.
So according to the Asan Medical Center's,
sure.
crossover from left main to aortic, how often this kind of circumflex,
Yeah.
in the
Start it.
future progression, that we need to do a target vessel revascularization for the circumflex osteo?
Yeah. Usually nowadays we don't do routine surveillance, angiographic surveillance for left main disease. It's not often. It's sometimes. It's a provisional stenting, sarcosteum narrowing per year less than 10 or less than 5. Yes, not much. Yeah, very often.
Yeah, but to be honest, whether you do a crossover, a provisional, or a two-stent technique, the most frequent place of restenosis in left main is the ostial circ.
Definitely.
Whatever the technique.
Yeah. So I think this patient has a good point. If after provisional stenting, sarcosteum was narrowing, how do you do next step? So that is our discussion point via this patient.
Previous stent procedures, when?
2 years ago. Yeah.
3 years ago?
2 years ago.
2 years ago, you did?
No, another faculty. Not me.
The reason why, all right. We don't have any, not frequent.
Yeah.
As I remember, maybe 10 to 15%.
I think it's too high.
Yeah.
All right. So,
can I ask a question, right? Before your discussion about the treatment, yesterday I just have a talk about the side branch treatment, right? This is one of my concern. And just after putting a stent, it's okay. There are no physiologically no stenosis. However, if there are some stot and link on the surface of the side branch orifice, membrane will make some stenosis.
Next.
So that is the reason why. But the main branch treatment is most important. So it is very important. But some sort of side branch treatment. But if you simply dilate this portion, I'm afraid the stent strut in the main branch will goes up to the main branch and make some stenosis, right?
So I'd like some opinion, stenting strategy. How do you treat such patient? Is any opinion from the panel?
Okay. How would you treat?
I would use a tap technique, minimal protrusion, just at the ostium of the circle. Then, of course, kissing and pump.
Okay. Akasaka?
Yes, me too, right? Yes.
Tap.
I would do as a kind of culotte technique, as an elective delayed culotte technique.
The size is not so. All right, culotte. Another.
3.5.
Drug-eluting balloon, I think, and if it didn't look good, then a culotte.
Right, balloon.
Maurice?
No, I think that at that stage it's difficult to treat the ostium of the circ without, let's say, damaging or whatever the main branch, which is the left main. So I would go to tap or culotte or we can try DEB, why not? But I'm afraid that it will damage anywhere the left main LAD.
Tree. What do you say?
I agree that it has to be a tap in terms of the configuration, the angulation. I don't want to put too much metal with the culotte, so tap is preferred.
But I think for tap, if you need to redo, it's very troublesome. I would prefer culotte.
Wow.
Different opinion.
You know, definitely, I expect that there are debating different opinion because of that we already predefine our strategy.
So at least you will find your technique in what has been said, because we said everything.
So okay, got it. So okay, I'm gonna do my procedure.
Yeah.
So we decided to, after the pre-discussion with SJ Park and our team, we try to do the Gulo technique.
Okay.
This
is where you said nothing.
This is so I'm gonna put the 3.5. Okay, this is a 3.5 balloon, and then I remove the previous beneath stand. This is suck. Okay, got it. Okay, and then I'm gonna do 자, 다리 한 사람 잡고 자, 테스트. 오케이, 고. 6, 8, 10, 12. 오케이, 디플릿. 자, 뒤에도 해주자. 자, 테스트 살짝. 자, 고. 고. 12, 14.
65.
디플릿. This is a 3.5 NC balloon. 자, 오케이, go. 20.
Big vessel.
Yes.
Still there are some indentation in the mid portion of the balloon.
Deplete.
So you want to, no, the long duration, high pressure is more than 20, 25.
Okay. 테스트.
What do you think?
자, 여기서 한번 가보자. 자, 고. 10, 12.
Maurice, for this kind of lesion, because in your practice in Paris, probably we would do the transradial. However, Asan, you are using a femoral
femoral,
common practice. What do you think? Transradial can be easily done for this kind of even left main bifurcation.
24.
Yes, honestly,
26,
it doesn't change anything for us because
deplete.
you have the same support in transradial and I don't know, probably it's 7 French guiding catheter. We did not ask. Is it 6 French or 7 French, the guiding?
Guiding.
Guiding is 8 French.
8 French.
8 French,
yeah. Usually the routine time, we sometimes select 7 French, but the live case demonstration, we have should think about lots of things, so usually prefer the larger size. You understand? Okay. Okay, Angel, ready? Okay, push up. Okay.
Probably
there is some
because of
change.
A-French, so you have to use femoral. Otherwise,
사이즈 하면 되겠다, 그죠?
now grass sheath slender has been available, so we can use a 7 French
Circumflex is
transradial.
good.
So
It is not so
as
good.
I told you,
Yeah,
right? Simple dilatation of the CX makes an stenosis in the LAD orifice stenosis
Yeah.
because
Yeah,
the strut goes up to the LAD, right? So might be.
This is
Yeah, there was
Stand.
so much disease in the circ, impossible not to push it in the LED.
okay, got it. Okay. Good. 자, 뒤에만 보면 돼. 자, 테스트. Okay,
But
which is
before
the
that,
top?
you have to
Spiral?
place balloon for the LED, right?
Yeah, right.
Balloon. Balloon
okay.
for the LED.
You mean I recross and then the clot.
You want to
tester?
do
Yeah,
clot.
clot. Yeah. Okay. Position.
Actually, one of the question regarding if the DCA available, would you do a DCA for the circumflex osteo plus DCB for this
Okay.
case?
테스트. 위치도 괜찮다, 그지? 잡고. 네.
12가 있습니다. 12.
Nowadays in Japan, you know, Dr. Akasaka, in Japan, osteal lesion, DCA plus DCD.
Yes,
Okay,
yes. But
deplet-
this case, there are strut in the side, so it might be
14.
very
Yeah, there
difficult.
is struts, you cannot
16.
cut
Yeah.
the stand.
Yeah.
Okay.
We like to use an DCA,
Okay, got
but
it.
this
And
is
then
special, right?
pull back the stand. You know, the next step is a recross and recross. Sock wire to LED, LED wire to sock. That is our next step.
But before you do this, how about you do a part for the left main, because sometimes you have a chance to, you know, withdraw the wire out
Yeah,
of
right,
the
right.
stand.
우리 파 해야지.
So part will be made safer.
마지막에.
요거
You have to
바꿔놓고
expand
하자.
more proximally.
Yeah, definitely. Okay, we're gonna do part, and that's just now. I'm gonna do the recross the wire.
So it's interesting to see that
spider
the
한번 볼까?
preference for the left main intervention to stenting technique is different. So just before this session, I had a question from one of my Japanese friends, and he asked me that why Asan Medical Center operators doing only crush.
Yeah.
You are not member of Asan Medical Center.
So that was the question I had. So that
Okay,
because that
tester.
they prefer culotte and they
Okay.
rarely do the crush, but the message he had was that he may think do more crush as he saw lots of very successful
only
cases.
some
So that I
Yeah.
think it's a learning, education, and the beauty of this kind of live
Yeah,
demonstration.
exactly. You have to use a technique that you know well and apply well. I think that's the most important.
Okay, got it.
That is our preference, as a more easier to perform and more safe for the patient. We think so. Procedure-wise, is more. Maybe this clot technique is maybe first one in this year, something like that. We didn't do too much of it.
And then I'm gonna pull back the LED and then sock. This is I save one wire. This is one. And then
So it's
remove
good to see that Dr. Dogubak is still did not forget all about culotte. So it's
okay.
if it's the first case this year, so that the
And
Okay.
a very important, nice thing is the tip of the circumflex wire never came out of the stent.
Yeah, right. Yeah.
It never came proximal
yeah,
to the
yeah.
stent.
That was one of important emphasis in the EBC club. Okay, this is a pull back to the. Okay, got it. 자, 그러면은 우리가 스몰 볼론으로 한번 저거 열어볼까? 좀 작은 볼론 나온 거 있어? 2.0이나 1.5도 괜찮고. 1.5 줘봐. And then we're gonna do small balloon And then finally 3.5, NC balloon high pressure dilation, and then re-evaluation.
Great.
IBUS.
What guide wire? What kind of guide wire?
Guide wire, one is the BMW wire, one is a Xion blue wire.
Xion blue.
Yes.
Why is good?
Yeah,
Rather
why
than-
is good?
Rather than your technique, right?
Yeah, you're right. The person is not important. Tech nowadays, person is much better. Yeah. Okay, this is 1.5, and for LAD, this is a small balloon.
What
Okay,
about
guys.
one of the
Good.
question,
Great.
maybe
자,
Akasaka also,
6, 8, 10,
OCT,
12, 14,
maybe you can see more
14,
precise
16.
of you go from different
Okay,
struts precisely, and what do you think in this kind of application?
16,
Still
18,
applicable OCT versus IVUS?
Okay, deeply.
I think in general the
18,
feasibility of the OCT in distal left main is
Okay, deeply.
more
Yes.
greater than
자, 3.5,
90%. So I think you can use the
Gyung-Min을
OCT
LED.
safely in the distal left main. And in such cases with a lot of metal, you can really see that where the wire is crossing. So the crossing point is really accessible with the OCT with the 3D construction. So that's probably the advantage of the OCT over the IVUS in such case.
15.
Dr. Park, can I ask you a question? So in your
Okay, got it.
center, are you concerned about recrossing the proximal strut, or you don't think it's an issue in case of bifurcation?
So we don't have a very strong clinical evidence, but we know that if you really take the proximal cell, you will create a long metallic carina. Especially in this case, it's a culotte. So you might have a 2 layer of the metallic carina, longly extending to the proximal part. So I think it's important to avoid such a long metallic carina, and by putting the wire in the distal cell, you can avoid it. So I think in that case, it's important to take the distal cell.
Yeah.
So in the there is a concern about how much overlap in the Kulo technique in the looking at the EBC recommendation, some Euro intervention article, at least 7 millimeter or at least 8. Is there any comment for that? Is it Maurice or any other member for how much overlap? As much as minimal?
As you want, as you want.
No, because I'm not sure it will change. Let's say left main was okay before, and
1번죠.
yeah.
So what's such a balloon for?
Yeah, this is, I'm gonna finally do 3.5, 3.5.
35.
Yeah, right. Final kissing was remain.
Yeah.
So in the Asan Medical Center, some 3 most commonly used stand culotte, crush, and tap technique. We prefer the crush technique. There is operation experience, but we can do also culotte and tap.
Yeah.
No, Dr. Park, I see that Asan doesn't use the DK crush. Is it that you don't believe it, or because you're using IVUS, it really doesn't matter because you optimize the results?
I'm gonna explain after ending of the kissing why. Okay, 자 LAD 먼저 가볼게. 조금만 더 뺄게.
네.
LAD지. 자 LAD 고. 10, 12, 14, 16, 18, 20. Okay, deplete. 자 조금 빼서. 자 섞어고 20, 22, 24. Okay, deplete. 자,
Disappear the indentation of the
Yeah.
ostial
Okay, got
sulcus.
it. 자, 간다.
And by
자,
arms findings, Dr. Park, actually the LED stand inside, there are some, superficial calcific neoatherosclerosis concern, and so we need a high pressure inflation for
definitely.
LED and
자,
25.
하면서 6,
6,
8,
8,
10, 10.
10.
Okay, 하나, 둘, 셋. Okay. And then you're gonna show the. Okay, ready?
So the finishing that final
shot.
kissing with our part
Okay.
is a common practice, or some the European operators
LED가 어떤
repart
거야?
again.
Prox LED.
이겁니다.
Yes, prox LED some hedges. I'm gonna once again. 이거 한번 해서 들어갈지 모르겠다.
Slowly.
Yeah.
Prox
여기
LED.
쏙. Yes. Okay, so we can check again. 야 이거 한번 했다고 안 들어간다. 자, okay, we're gonna check the IBUS. 열리긴 다 열렸는데. Okay, got it. So some decay crush is theoretically is good, but as shown here now, some if you use the non-compliant balloon at once, recross is very difficult. But decay crush, require one part and the one kissing balloon dilation. And at the end of a final kissing balloon dilation, usually there are many chances do not use the non-compliant balloon. We require additional 2 non-compliant balloons. There is some resource problem, something like that. So
LED입니다.
LED. Okay, got it. Okay, I'm gonna do IBUS from LED. 오케이, 자 조금만 쫓아오세요.
네.
자 여기서부터 자 고. Okay, this is prox LED.
27 distal.
Yeah, this is prox LED OS. Yeah, previous 3.0 stand. We do using final kissing using 3.5. Okay, I think lumen is good. 좀 12의 칼슘 때문에 저렇게 익센트릭하게 보이는구나. Okay, and then the recheck from the sock. 조금만 더 메인 오스까지 조금만 더 보자. 이런 거. Okay, and then we're gonna check again the sock to the main. So if the suck ostium ISR occur, I think that there is some option. If two-stand strategy, there is ISR, we frequently use DB. It's a drug corridor balloon LED, drug corridor balloon suck. There is we usually try to avoid the additional metal stand, but such region, we select the gullet, sometimes tap, and the suck ostium is relatively just a small plug. We sometimes do DB. 오케이, 조금만 더 들어가자 뒤에. 오케이, 고.
3O.
Yeah, this is 3O. We finally performed the 3.5 NC balloon, 3.5 NC balloon.
Distal landing is good.
Yeah.
Landing is very good.
2, 7, 3O. Effective stand area is quite enough. More than 7, 8 millimeters.
We performed the 3.5 up to high pressure 25, 30 suck ostium, LED ostium. We do final kissing.
그냥 ostial part is good. More than 3 stand diameter. We use the 35 non-compliant balloon.
Yeah, right. Okay, coming the LED to 6 o'clock. I think opening is good.
Yeah.
So I'm gonna check another view, area coral view.
Dr. Bo, would you show us again LED on the main pullback?
Okay, LED main pullback. I will
part of a proximal LED.
Yeah, the proximal, there was some flattening.
Some corona shaped and
LED부터. 자, 고.
Yeah, this.
Yeah, this is LED to the main.
Would you show us the previous?
다시.
Alright,
다시 한번.
좀 깊게부터
오케이, 여기서부터.
Okay.
Okay.
Is it ready?
Yeah, this is LED to the main.
Still eccentric.
Okay, I'm
I
gonna.
think it's okay. However, if you look at it, asymmetry, of a very proximal LED.
I can do one more time. The kissing balloon. Okay, and you're ready?
So I think it's high pressure, almost 25 consecutive dilation with
Yeah.
shock and LED. And then once again.
Okay. Okay, I think we do additional fine tuning using non-compliant balloon. Is after the ending, I'm gonna show again. Okay.
We're gonna move another room,
Okay, got it.
and we'll be back, Dr. Park.
Yes, should.
Okay.
Okay. 자, 그러면 NC를 한번 다시 줘봐봐.
Yeah, it's
Dr.
visible in angio also. A little bit.
세게 한번 해보자.
Yeah.
저기 어떻게 벌어질지. 3.5, 3.5.
Dr.
비슷한 크기로 돼야 되는데.
Okay. Can you hear me?
Yes, I can hear you.
Hello.
Can you hear me?
Yes,
Yeah.
very well.
Yeah. Good afternoon.
Good afternoon.
Yeah.
We have very distinguished panel and moderator here. So, okay, explain.
Okay. This is Professor Kang, my previous fellow, but working for the Bundang Cha University.
Yeah.
And so, could you explain the patient history?
Yeah, our patient is 62-year-old female and admitted for chest pain, started from 7 months ago. Her coronary risk factor was diabetes, and she underwent PCI at proximal to medial RD and distal RCA 7 years ago from the other hospital. And she had another PCI from left main to proximal RID about 6 years ago. At this time, coronary angiogram showed severe stenosis at proximal circumflex and diffuse severe stenosis at proximal to medial RCA. And there was some instantly stenosis of the distal, distal edge. So we performed PCI for RCA about 3 weeks ago. The past medical history showed the whole left main to proximal RID. Previous stent was a lateral integrity 3O, 22 millimeter. Next. And she had the diabetes, and the clinical presentation was stable angina. Next. The echocardiography showed the normal LV systolic function, and the left coronary angiography showed severe stenosis at proximal circumflex, and instantly stenosis of the medial RAD, and the FFR value from the medial RAD was 0.68. And we performed PCI for RCA about 3 weeks ago, so we focused on left today. And her syntax score was 24.
Okay, do you have any comment? This is a coronary angiogram today. So the circle is, looks small, but you can see the circumflex is supplying the LV, the apex. So circumflex is not so small range, and circle ostium is very tight and heavily calcified. Next, please. Yes, very tight circle ostium, diffuse disease. Next, please. So stent distal tight stenosis. So due to this tight stenosis, FFR value is down to the 0.65. Next, please. So we've done. So next, please. And then we treated first the distal the LAD. Next, please. Next, high pressure, 2.5 stent, 18 millimeters, and I'd like to move to the left main circumflex ostial stenosis. Okay. Could you show us? Yes. Could you show us the?
You want to focus on the circumflex remain.
Yeah, right.
One of the question
Sure.
after you fixing the mid distal stent, putting a stent, did you do another FFR study to see?
No,
because we
no.
can see a diffuse neointimal tissue inside the original resolute stents. What do you think doing a FFR? You think it's satisfied?
Yes, FFR value should be not so high, but based on the IVUS guided intervention for the LAD stent, so even though there is a low FFR value, we don't have something too more. So the practically post-stent FFR in this case, without IVUS, yes, but with the IVUS, the practical meaning of post-stent FFR, I don't think this is meaningful. So I don't like to measure the post-PCI FFR if you do the IVUS guided PCI. So
Can I ask a question to the panel? So this lady was a three-vessel disease. Would you consider, just because of diabetes, because she was also diabetes and a young patient, would you consider CABG as an option, or you didn't consider CABG at all?
What do you think, CABG option?
Yes, CABG is a good option for this patient. But we always discuss with the patient and family, but many Korean patients don't like to have a bypass surgery. So I don't like to touch the distal lesion because we have to save the distal lesion for future bypass surgery.
Yeah, distal lesion was not good for Lima. So, yeah.
Next.
So any suggestion from the panel for circumflex lesions? Circumflex lesion, Onuma? Any suggestion for the circumflex is calcify the small vessels?
Yeah.
And so I think you fix up the right coronary artery and LAD distal.
So the question is that when the first stent was implanted, is that opened for the side branch? Side branch was fenestrated, or is just
60 years ago, but didn't do open.
Yeah, probably crossover.
Yeah, just a crossover.
All right.
So compared with previous case, the orifice of the CX is a little bit distal and just proximal to the carina. This might be much easier to open because the previous stent goes to the proximal side of the CX. So simple dilatation makes some change, and there are no stenosis in the LAD, so it might be
Is there
much
any
easier.
other difficulties to pass the wire?
No, wire is really
easy.
insert.
It was not easy. You made it easy.
Next, please. So there is some heavy calcification. Pre-region modification is very important. Just after the wire insersion, circle flow gone.
Yeah, it's
so
gone.
I applied.
Very tight stenosis, right?
Yes, I tried to insert a balloon, but not easy. So using the anchor balloon technique. Next, please. This is a 2.0 high pressure balloon. Next, and next, please. Several times 2.0 high pressure balloon. Next. So next, please. And IVUS. Next, please. I will show you IVUS next. Next, please. So I already applied 2.5 high pressure balloon. Next. Yes, this is the current status. Could you show us IVUS for circumflex?
Right.
Here is the distal circumflex. The vessel size is 3.0, less than 3.0. Very diffuse. Yeah, 2.5. Yeah. 2.5. Yes.
Yeah.
So
very diseased,
heavy calcified.
Diffused is right.
Yeah.
Diffused
Getting
disease.
bigger. Encircling calcium.
Yeah.
The reason why is very the breakdown after the balloon.
Yeah.
2 o'clock and 6 o'clock. And vessel size wise,
2.5. Proximal portion
right,
is
2.5,
3.0.
3.0 something.
Yeah.
1, 2, 3, 1, 2, 3, more than 3 something, right?
Yeah, right.
Getting bigger. And
Here is very proximal.
calcium thickness is
Yeah,
quite.
but you can see there's some disruption of a calcium arc at the 6 o'clock. Yeah. Here is the proximal stop, the 3.0 soft
3.0.
looking plaque.
Large plaque with
Very tight
localized
stenosis.
calcium. All right.
Yeah, here is the left main.
Diffuse disease.
Yes, left main stent size is 3.0, but definitely we need further balloon dilatation. Left main size is more than 3.0, and
Main
it's
here,
4.0.
yeah, it clearly under expansion, right?
Yeah, under expansion.
Compared with
yeah.
vessel size wise.
Yeah. So, ready?
Ready.
Okay, this is the current status.
So what would you do there?
Yes, actually, balloon result it looks nice, but the clinical problem is the lesion length, stent length. So how can I decide the distal landing? This is a problem.
Stent landing?
Yeah.
All right.
The basically very diffuse disease.
It's
So
very diffuse, yeah.
Yeah. I'd like to select 38.
38?
Yeah, 38, 2.5. Please give me the 38, 2.5.
Doctor, another alternative, if you can do for lesion modification, for example, using after you high pressure 2.5, you can, I don't know if still cutting can go. We can just do cutting and DCB. That is another option because this is a long, diffuse, small vessel. So you're putting a metallic stent that would be also in the future. I don't know, it's a recurrent, restenosis rate still high.
Yes, I fully agree with your opinion. In my mind, I also have another option, DEB, full lesion modification and DEB, because after balloon dilatation, balloon result is better than my expectation. So DEB alone would be a good option.
Proximal 23, 24, 3.0 stent with a distal part, a relatively small 2.5 vessel with a DEB.
DEB, yeah,
All right.
yeah, that could be an option, yeah.
It's up to you.
Okay, so I'd like to insert 38. Is it possible to insert the 38? So already there is an anchor balloon at LAD.
Maybe some difficulties.
And this is the left Judkins.
Okay.
It's a left Judkins guiding cap.
Yes, right, Judkins A French.
And that's your first choice for a circumflex? Well, you were right, but...
Great. Balloon anchoring at the LED part and pushing, it works.
Yeah, this is my preference. Judkins is my preference.
You have to care about LED side in the later.
Yeah.
And further.
Okay.
Be careful.
Deflation.
I think it's okay. You want to do kind of a reverse crush or something?
Yes, right.
Right.
Yeah.
Minimal protrusion and...
Yeah, minimal protrusion.
Right.
Yeah.
It looks okay?
Yeah.
Yeah, we have 1 millimeter inside the LED.
1 millimeter, okay. Inflation? 8. 8. Nominal 12 for A. Small balloon first.
Circumflex ostium is not dilated.
Deflation. 10. 12. 14. Deflation. So please give me the 2.5 high pressure balloon.
What do you think of 275? In terms of proximal part is relatively big one, right? 3.0 something.
Yes, right.
So if we want to do circumflex ostial but high pressure, I think a 275 and 3 up to 3.0 something.
Yes, I will select the 275 to the circumflex ostium. After the correction of distal circumflex, and then I change the balloon size to the 275. This is 2.5 high pressure. Deflation. 14. 16, 18. Deflation. Okay, proximal portion is very big. 20. 24. Deflation. Please give me the 2.75 high pressure balloon. 20, 24. 24. Deflation. So ready? Ready. It looks fine. Yeah.
Looks good.
Just 275. My concern is that these are landing, but after correction of left main, and then I will see by IVUS. These are landing over circumflex stent. This is 275. Okay, proximal is very big. 20. 2.9.
2.9.
Yes. 24. 24. Depletion. Okay, I need a crochet. I can remove the whole wire, whole system of circ.
Good.
And ready, 20, 24. This is a 3O high pressure balloon.
3O?
Deflation. Yes, deflation. So definitely we need a big balloon. 28. Oh,
So you are converted to become a mini crush because
Yes,
minimal
right.
protrusion you are now crush.
yeah. Deflation. Please give me the 3.5. What is the main size?
3O,
show us?
so relatively small, right?
4O, please.
Yeah.
4,
Yeah.
4O for the main area,
Yes,
right?
right,
Good.
right.
It was underexpanded at the last procedure. Yeah.
Please give me the 4O high pressure balloon.
For LED.
Yes, right.
The OCT versus IVUS, it seems like IVUS is somewhat overestimate the vessel and OCT is more precise. So I'm asking two of the OCT experts, Akasaka and also Onuma, what do you think this kind of
Deflation.
in the clinical practice?
Yeah, I think, if you look at the difference between the IVUS and OCT in terms of lumen area, certainly the IVUS is overestimating compared to the OCT, which is very close to the phantom or the real dimension. But I think here the advantage of the IVUS is being able to evaluate the EM and vessel area, and I would say that because it is a stented segment, the OCT could be also nice to see all the expansion of the stent. But I think being able to seeing the EM is also the advantage of the IVUS in such cases, especially to decide the proximal part of sizing of the proximal part segment.
Dr. Hahn,
Yes.
what did you do next?
Rewire to the sock and final kissing.
Okay.
Then I'm
So
done.
we will back. We want to just drop by Dr. Bak's final
Okay.
result, all right?
Okay.
And we will be back. Okay. Dr. Bak, can you hear me?
Okay, come
All
back.
right.
Yeah, okay. So can you see the angiogram? Can you see the angio?
Okay.
Right, here.
Right.
Okay. Yeah, this is just the immediate after 3.5, 3.5 non-compliant balloon is
Okay.
as you already shows, and most of the audience relatively satisfied, not fully satisfied. Because I can stop that procedure at that such atmosphere. So I did something. So it's I select another balloon. It's LAD 3.75, much bigger balloon.
Great.
Yeah, SOC is a 3.5 balloon. So I do nearly high pressure inflation of the 30 ATM using 3.75, nearly 4.0, 2 times. And then SOC is a high pressure balloon dilation of the 25, 30 ATM using 3.5. This is a final kissing, LAD 3.75. The SOC is 3.5. It's several times. 1 time, 2 times, and then 3 times, and then it's a, there is some change. Yeah.
Much better.
Much better.
Yeah, much better.
Much better, yeah.
And then this is our coral view, much better.
Yeah.
Yes, atmosphere some change. So, okay, we checked the IVUS. Okay, could you show us LAD to left main? Yes, this is LAD to left main. The LAD ostium is standard. Okay, much better. People, this is LAD ostium over here. Can you show again? 딱 들어오는
Absolute area is big,
아니, 뒤로 갈 필요 없고 딱 그 부분만. Okay, go.
All right.
This is the LAD ostium and sulc ostium is coming much better than before. And then could you show the sulc to the left main? 쭉 그 앞에 들어오는 부분만 보이죠. Okay. Here is coming the LAD ostium in the 6 o'clock. Okay, it's a widely open the distal part. This main part is widely open, and you finally use additional blood 3.75, 3.5 aggressive high pressure dilation, and then we make some change. This is a final shot of the area coral view. This is the final shot of the spider view. I think I do my best for this procedure.
Okay.
Really excellent, yeah.
Any comment on that? It's really great demonstration. It's a cool technique. All right. Thank you for that. All right.
Thank you. Thank you. Thank you. Thank you. Thank you.
Dr. Hahn.
Yes, I rewired already. So, and I insert for the circle balloon delivery. For anchoring, I insert 3O balloon to the LAD first. Circle also may be very tight. I think tight. So starting with 2.0, previous used high pressure balloon.
You want to use 275?
This one is 2.0. Just open the circle ostium. Oh, easy.
Yeah,
10.
easy to cross, yeah.
10, 12, 13, 14. No. Circle place.
So, Marie, it's one of the questions regarding if you stay with the TAP without just, become a convert into a mini crush. What do you think that long-term result will be somewhat inferior to the crush here? Because if you just have 1 millimeter protruding and you have enough space in the left main, you find out with alternative high pressure and kissing balloon simultaneously. What do you think? Which is a bad result? Or?
No, I think the protrusion was really minimal, and doing the kissing, you also put it against the wall. Instead of making the two on the same side, you have one on each side. So I think it should work too.
12, 13, 14,
again,
16,
when you are
18,
used to a technique, you do
20.
it properly. And,
275.
275.
18, 20.
20.
Deflation. LAD 20. 24. 28. This is a 3.0.
3.0.
Deflation. Yes, deflation. And 10. 하나, 둘, 셋. Okay. I'd like to see the circ. I was first to see the carina and circ costume. My concern is how big circ costume is and the location of carina. And this edge of circle stand.
This angle is, big angle at the radian circumflex. I don't too much concern about the compromise. And however, okay.
Ready? Ready. Before I was.
Look good.
some indentation,
Yeah.
but considering the very calcified lesion,
Yes.
Yeah,
this is
yeah.
acceptable result. Sometimes the
Yeah,
perfection is
flumen
the
is,
enemy of good.
Is good. That's
Let's just see
Others?
the distal.
yeah.
Okay, here is two distal.
Very far.
Again, a very
Yeah, very
diseased
far.
vessel, distally. Yeah.
Okay, wrong please. Okay.
2.5, sorry, 8, right?
Here must be the distal landing.
Yeah.
Here, good.
Yeah, which is very clean. Yeah.
Yeah. No dissection. I can apply the more high pressure using the 2.5 balloon because the vessel is getting bigger. So I think the 2.5 high pressure is safe.
Right.
Even distal
2.5 high
side.
pressure for the distal part.
Yeah.
You may need that.
When you pull back, proximal portion, I applied 275 up to 20. 275 up to 20 means 2.8 millimeter or something, but still it's underexpanded compared to the vessel. But I think this is acceptable range. Here is the ostium. What do you think about? Do I need a further balloon dilatation?
So you want to use a 2.5 or 2.75?
Yes, 2.5 first to the distal and 2.75 for the proximal.
7.5 for proximal.
Yeah, again.
From the middle portion to
Yeah,
proximal is
to
2.75. Far distal is 2.5.
Fortunately, my
Again,
distal
it's very
landing.
calcified and diffusely diseased vessel.
Yeah. Even though I applied very high pressure and lesion pre-modification, in this case, please stereo, high pressure please. In this case, the stent expansion is not good. So anyway, for treatment of a very calcified lesion pre-modification is the most important thing.
Before stent, right?
Yes, before stent. After stent, the expansion of a stent is very limited. 세관계 주세요. 네, 3.5 세관계 주세요. Suck. Inflation. No, not yet. Calcification and the mechanical stress of stent strut, so balloon delivery is not easy. Balloon is not delivered. What happened? Do I have more time?
Can I ask a quick question?
Yes.
So, this is a young lady with apparently no risk factors for bleeding. Now she has a full metal jacket of LED, 2 stent in the left main, 1 long stent in the circuit in the RCA. Would you consider giving dual antiplatelet therapy longer than 1 year in this patient? Or, I mean, how long are you going to give DAPT in this patient?
So for the left main disease, we don't change the dual antiplatelet strength of antiplatelet treatment because left main, even left main disease, the stent thrombosis risk is relatively lower than non-left main disease. So considering left main disease,
in this case, it's not only left main disease. It's left main disease with 2 stents, full metal jacket of LED and circ. So a complex case.
Yes, it's very full metallic case. So if a patient have the low breathing risk, so I like to prescribe the dural antiplatelet indefinitely. I try lifelong depth, unless she complained the breathing complication.
Dr. Hahn,
Yes.
you may take a little bit more time, right?
Okay.
So you're going to move lecture session and we'll be back for the final result, right?
Okay, thank you.
Okay.
Thank
good
you.
Cases.
Thank you.
Thank you. Very good case. Thank you. We go now to the first lecture, which is Iris PCI, Mechanical Support Device Options. And it's Michael Lee who will give the lecture. Michael, please.
Great, Dr. Maurice, thank you. And Dr. Park, again, thank you so much for the kind invitation. It's always a pleasure and honor to be here today. So in the United States, we generally have 3 percutaneous options for hemodynamic assist: the balloon pump, Impella, and Ecmo. First, let's start with the balloon pump. Everybody's used it. It's very familiar to us. It's easy to implant. It's inexpensive, roughly about $800 US, relatively small bore size for arterial access, 7 to 8 French sheath. The disadvantages are the following. It doesn't really increase your cardiac output all that much. We're looking about 0.5 liters per minute. This is an example where we implemented the balloon pump to help us get us through the PCI. This was about 7, 8 years ago. This is a gentleman who came off the plane at LAX, was transferred to our center with profound hypotension, was transferred to the cath lab, was found to have a thrombotic lesion in the left main. At this point, what do? There's some concern that if we do PCI, the patient eventually dies, at least in the United States. There is some trepidation about litigious action by the patient. But still, we thought that it was best that we proceed for PCI. So just by traversing a wire through the left main, you have some restoration of flow. This led to some improvement in hemodynamic as well as electrical instability. That's a very straightforward PCI. You can see there's just a very straightforward mid-left main lesion. We addressed this with a 4.0 by 15 millimeter everolimus eluting stent. After just 1 stent implantation, the patient did very well and was actually discharged 4 days from the day of acute myocardial infarction. So we use it commonly, but then again, where is the data? Well, the data has been actually disappointing. For elective PCIs, looking at the BCIS trial, patients who underwent elective balloon pump insertion had no benefit from no planned insertion of a balloon pump, no benefit in terms of 6-month mortality. What about the sickest patients? So these patients in the IBP SHOCK 2 trial, all of them had LAD infarcts complicated by cardiogenic shock. So the blood pressure was less than 90 millimeters per mercury. No benefit, balloon pump versus control. So where's the data? Unfortunately, there is none. Our usage of balloon pumps at our institution is dramatically falling because of the paucity of data to support its use. In many geographies, especially in Korea, for example, Impella is not available. At our institution, we use this quite liberally when indicated. The benefits are the following. It does provide a relatively good amount of cardiac output. The CP device has about 3.5 liters per minute. You could use up to 7 days, upwards up to 14 days. Even if you have electrical instability, let's say you have recurrent VFib, VT, it still provides hemodynamic support. But the main benefit for hemodynamics is unloading the ventricle, so you're letting the LV heal. The disadvantages are the following. It's a relatively large bore catheter. It's susceptible to bleeding. You have to continue heparin while the device is implanted. It's non-pulsatile flow, so it's non-physiologic. And the cost, we talk about cost constraints. We're talking about a $20,000 device. So if we're going to use it, you really have to use it selectively and judiciously. This is an example I thought that was very useful to use elective implantation of Impella. So this is an 85-year-old male with multiple comorbidities, had kidney disease, had polio, had a restrictive lung disease. So you can imagine if he goes for CABG, post-operatively trying to extubate this patient would be quite difficult. This ejection fraction is very poor, maybe 10%. So we have a CTO of a right coronary artery, we have a distal bifurcation lesion, we have a long diffuse LAD, we've got disease in the left circumflex system. What do you do for these patients? But clearly, CABG not being an option, we decided to use Impella to support us through the PCI. Given the severe coronary calcification, we thought that atherectomy was a reasonable strategy for plaque modification prior to definitive stenting. So we decided to do a balloon pump, Impella, with a pacemaker. Because of the severe calcium, we decided to do plaque modification with rotational atherectomy, followed by the crush technique. Amazing how these patients with mechanical support device are hemodynamically stable, and it really allows you to focus on the patient as well as to focus on the hemodynamics. So what data do we have for Impella use? Well, in this study called the PROTECT-2 trial, over 650 patients, either you had left main disease or last remaining conduit and an ejection fraction of less than or equal to 35%, or an EF less than or equal to 30% with triple vessel disease, randomized 1-to-1 to balloon pump or Impella. Primary endpoint was 30-day major adverse events. If we look at intention to treat, at 30 days as well as 90 days, there's no benefit with Impella compared to balloon pump. However, per protocol, if you look at 90-day follow-up, there is a significant reduction in major adverse events. We think that perhaps the earlier event rates being higher or no significance probably is related to the fact that many of the patients who are randomized to Impella underwent rotational atherectomy, which may explain a higher rate of peri-procedure myocardial infarction. However, at 90 days, patients did benefit from Impella. And finally, Ecmo. This strategy is really reserved for patients who are in extremis, patients who present to the hospital in cardiogenic shock or in cardiac arrest. It provides over 4.5 liters per minute. It can be used up to a month. After a month, you really have to decide whether you have to switch over to something more durable like a Centramag. Similar to Impella, you do not need a stable rhythm, so you could be in VT, VFib, and still have Ecmo to supply hemodynamic support. Another advantage is that you can actually implant it in the ER with that fluoroscopy, so you just have to get access through the femoral vein, femoral artery. However, you do have large bore catheters, which puts the patient susceptible for bleeding complications. One of the disadvantages also is that it increases afterload. So imagine having a cannula in the femoral artery, you're pumping in blood, obviously increases afterload, which is deleterious to hemodynamics. The cost is also prohibitive, $25,000 plus the resources. You have to have a perfusionist at bedside the whole time to monitor these patients. This is a young patient, a 49-year-old male who presents to the ER with chest pain. He actually arrested in the emergency room. So we took him to the ER, or to the cath lab, and the first shot we have here is an aortic angiogram. We thought we perhaps had an aortic dissection. There was no aortic dissection. Then coronary angiography review is a thrombotic left main occlusion. There's no flow in the circumflex. The circumflex was actually the dominant vessel, which explains why the patient had inferior ST elevations. Well, our cath lab worked vigorously doing chest compressions at the same time. And the patient was actually in cardiac standstill, and you can see a J-wire, which was a wire put in from the contralateral groin to get Ecmo support. So after the stent is implanted, you can see the circumflex ostium occluded, basically still cardiac standstill. After we wired the circumflex, patient had restoration of flow. If you look very carefully, the heart's just fibrillating, but the patient still has a blood pressure. So that's one of the remarkable things about Ecmo. The patient had undergone numerous or defibrillations, couldn't get him out of VFib. The patient surprisingly survived, but ultimately passed away from ongoing overwhelming sepsis. This is another 48-year-old male, so we kind of have an epidemic of 40s patients having severe coronary disease. This patient had a cardiac arrest at an outside hospital, was transferred to our center for advanced therapies. You can see just the diffuseness of the coronary disease. He's got left main disease, he's got LAD, circumflex, diagonal disease, in a 48-year-old male with diabetes on multiple pressors. Clearly, bypass surgery is not an option. Advanced therapies were not an option given his underlying history of coccidioidomycosis, also known as valley fever. He thought because of this was not a candidate for a heart transplant. Given the severe calcium, he thought the atherectomy was a reasonable option. So we chose orbital atherectomy. Imagine this, he's on 4 pressors, so you can imagine the vasoconstriction that's happening in his coronary arteries. So after we inflated this gentleman was about 98 kilograms, he certainly wasn't a small gentleman. Just by putting a 275 millimeter stent, the patient had a large perforation. The patient did not have a perforation after atherectomy. Despite this perforation, this patient was completely stable on Ecmo, very miraculously. So after we put a covered stent in, we went to a traditional view and the iliocranial view, addressed the left main, had cessation of the active perforation and extravasation of contrast. Patient went upstairs. He was actually awake. But because of ongoing infection, we thought that it was not a good candidate for advanced therapies, and the kid was eventually drawn. I've shown you some cases of acute myocardial infarction due to left main disease. What data do we have? This is data where we combined data from Colombo's group, 62 patients. A quarter of these patients were in cardiogenic shock. Overall survival at 5 years was about 75%. The patients who died all died within hospital stay. So I would argue whether they went for bypass surgery or PCI, it really doesn't make any difference. But once they underwent revascularization, these patients did very well. Interestingly, patients with STEMI versus no STEMI had similar results. So the main benefit of left main PCI is that you could go from the cath lab and you could get immediate revascularization, whereas in the best case scenario in the middle of the day, going from the cath lab to the OR, calling an anesthesiologist, perfusionist, surgeon, clearing OR time is very difficult. In fact, you'd probably be minimum 1 hour, and that's being very conservative. So what do we do for these patients? Well, Dr. Park, myself, Dr. Stone put forth a state-of-the-art paper, an absent of a randomized trial, which would be very difficult to do because of logistics, and randomize these patients was almost impossible. We thought emergent PCI was a very reasonable strategy to open up these patients and get reperfusion. So now the guidelines endorse a class 2A recommendation for left main PCI. So you may recognize this patient. This is Kareem Abdul-Jabbar, arguably one of the greatest basketball players of all time. He actually went to UCLA, and for those who don't know, he had bypass surgery. He has coronary disease. So I'm not that short, but compared to Kareem Abdul-Jabbar, I look like a midget. So, but his coach was John Wooden, and he was a 10-time NCAA champion, arguably one of the greatest coaches of all time. And this is what he would tell his pupils: failing to prepare is preparing to fail. Thank you.
Thank you. Excellent.
Case first. All right.
Yeah.
They are waiting. All right.
Oh, they are waiting. Okay,
All right.
let's go back to the... Yeah.
Doctor?
Yeah.
So we already...
Okay, right. I'll just show the final result.
Next, I applied high pressure again, 275, final kissing, one more kissing. Final shot, please. High pressure 4-0. This is a caudal view. Next. This is spider view.
Oh, great, great.
Great. Huh?
Right,
yes, the sub-costume looks good.
Yeah,
so I like to
better
finish
than,
my
yeah.
procedure.
Okay. What about, could you tell us the obvious findings, the minimal lumen stent area, circumflex ostium?
4.5, not
4.5.
5. Yeah,
Great.
not 5.
I think it's great. Yeah, the reason why the basically...
When you see the lesion at the beginning, honestly, it's
very much calcific lesions, right? Okay.
No, it's very good result.
Good.
Thank you.
Angiographic findings.
Thank you.
Nice
Thank you.
case,
Thank you, Maurice,
demonstration.
Dr. Park. Thank you.
Okay.
So last lecture is a PCI in high bleeding risk patient by Joo-Yong Han.
Thank you, Dr. Morris and Dr. Park. I'm Joo-Yong Han from Samsung Medical Center, Seoul, Korea. These are my disclosure. The bleeding after PCI is not uncommon. In the ADAPT-DS study, the rate of any bleeding was reported to be 6.6% at 2 years. Gastrointestinal bleeding was most frequent, followed by peripheral, genitourinary, and CNS. Moreover, bleeding has an impact on mortality. In a pooled analysis, patients with any bleeding showed a higher risk of mortality than those without bleeding. The association between bleeding and mortality was as strong as that association between MI and mortality. Post-discharge bleeding also has a significant association between all-cause mortality and cardiac mortality. The results were consistent in a landmark analysis at 1 month and 1 year. In the ADAPT-DS study, predictors of a post-discharge bleeding were age, use of warfarin at discharge, peripheral artery disease, complex lesion, hyperresponsiveness to clopidogrel, and anemia. However, until recently, no standardized tool exists for weighing risk of bleeding before determination of DAPT duration. The precise STEP score is a simple 5-item risk score to provide standardized tool for predicting bleeding risk on DAPT. Patients in the high-risk group classified as risk score of 25 or higher has a significantly greater risk of bleeding compared with other groups in deviation cohort and validation cohort. Patients in the high-risk group for bleeding did not benefit from prolonged DAPT in terms of prevention of ischemic event and had a significantly higher risk of bleeding. After identification of high-risk bleeding patients, some special consideration is needed for appropriate treatment. One of the important issues is selection of stents. Previously, bare metal stents was considered the standard for this population because 1 month DAPT is a standard for BMS. There have been 3 randomized trials for evaluation of DS compared with the BMS in this population. The first one is leaders-free trial. Dr. Philip Urban, one of this panel in this session, and co-investigators compared biofreedom drug-coated stents with bare metal stents in high bleeding risk patients. In the JEVS trial, jutarolumab Endeavor sprint stents was compared with bare metal stent in uncertain candidates for DS, including high bleeding risk patients. The inclusion criteria seems to be uncertain to me. And in the senior trial, Synergy was compared with the BMS in patients 75 years or older. Because Leaders Free trial was the largest and only one dedicated to high bleeding risk patients, let's look into the Leaders Free trial in more detail. This trial, double-blind randomized trial, a total of 2,466 high bleeding risk patients were randomly assigned to biofreedom drug-coating stents versus bare metal stents. DAPT was mandated for 1 month only. Inclusion criteria were old age, oral anticoagulant, anemia, a previous history of intracranial bleeding and severe liver disease, and so on. The primary efficacy endpoint of clinically driven TLR occurred less frequently with biofreedom stents compared with bare metal stents. The rate of cardiac death, MI, stent thrombosis, was also significantly lower with biofreedom stents compared with bare metal stents. The rate of bleeding was very similar between the two groups. Therefore, this study demonstrated the safety and the efficacy of biofreedom drug-eluting stents in high bleeding risk patients. The most recent 2018 ESC guidelines on myocardial revascularization recommend 6 months DAPT in patients with stable ischemic heart disease and 12 months DAPT in patients with ACS. However, they also recommend short DAPT, that is 1 or 3 months DAPT in stable ischemic heart disease and 6 months DAPT in patients with ACS if they have a high bleeding risk. The high bleeding risk can be assessed using precise depth score, as I mentioned previously. There are several ongoing trials in high bleeding risk patients. In the Onyx-1 trial, Onyx will be compared with the biofreedom stent, and the patients in both groups will receive only 1 month DAPT. So this trial will demonstrate and compare drug-eluting stent versus drug-eluting stent in high bleeding risk patients. In the master adapted trial, patients will receive one type of stent, Ultimaster family, and they will be randomly assigned to 1 month versus 5 months or longer DAPT. And Giants 28 trial is a one-arm registry of Giants family on HBR patients. After these trials are complete, we have more confident data regarding short-term DAPT in patients with high bleeding risk and undergoing PCI with drug-eluting stents. Nowadays, P2Y12 inhibitor monotherapy becomes popular. I would like to present the results of our Smart Choice trial very briefly. This was a multicenter, randomized, open-label, and non-inferiority trial. A total of 3,000 patients underwent PCI using 3 types of current generation DS. Patients were randomly assigned to P2Y12 inhibitor monotherapy after 3 months DAPT and or 12 months DAPT. The randomization was stratified by center, type of stent, ACS, and P2Y12 inhibitors. The primary endpoint was death, MI, or stroke. At 12 months, the rate of MACCE was 2.5% with 12 months DAPT and 2.9% with P2Y12 inhibitor monotherapy. The non-inferiority of 3 months DAPT followed by P2Y12 inhibitor monotherapy was met compared with 12 months DAPT. As expected, the risk of bleeding was significantly lower with P2Y12 inhibitor monotherapy than with dual antiplatelet therapy. In summary, post-discharge bleeding is not uncommon and has a strong relationship with the subsequent all-cause mortality comparable to or greater than that of MI. To identify patients with high bleeding risk is of great importance. Precise DAPT score is a simple but standardized tool. DS have shown superior efficacy and comparable safety compared with bare metal stents in high bleeding risk patients. Short duration of DAPT needs to be considered in this population. Finally, P2Y12 inhibitor monotherapy after short duration DAPT can be another option for this population. Thank you for your attention.
Thank you. I think we have a little time for discussion. Philippe, we can consider you as the father of the HBR patients. So, do you have comments to make on the wonderful lecture that we just heard, or question to the speaker?
Congratulations for a very nice review. And you said so, but I think it's important to make a difference between HBR patients who often would be better off with long DAP, but who cannot because it's dangerous, versus patients who are low to moderate risk, in whom they don't really need DAPT, but it's not a question of safety. And so I think it would be always important to see the MI rate, or MI and ST rate on one side, and the major bleeding, BARC 3 and 5 on the other, so that we can see what risk and what benefit we derive. You showed us BARC 2 to 5, which is important, but not, to me, as important as BARC 3 to 5. But congratulations for a very nice trial, and it fits nicely with Stop DAP2, and also maybe it's something that's applicable to Asian patients better than to European or US patients. All of those issues are open.
One of the questions regarding HBR patient, because already on NOAC for example, chronic AF. Then this kind of patient right now only have some trial talking combination with one single platelets. This morning we have discussion regarding single clopidogrel plus NOAC. Is that safe for example, today there's live demonstration, lab-made modification. Is that safe, or people still like to have at least European guideline DAPT for maybe 2-3 months, and after that you taper it into a 1 month?
It's again going to be a trade-off of bleeding and thrombosis. If it's a very simple angioplasty, maybe you could stop aspirin at discharge. If it's a complex procedure, I'm still worried that people seem to think that you should forget DAPT from hospital discharge. For instance, in the latest trial, the Augustus, we have to remember that people were on aspirin for a week or two before they were randomized. So when you say get rid of aspirin, it means get rid of aspirin after 1 or 2 weeks. I don't think that issue is completely resolved yet, and I think for the moment it's case by case. That's my opinion.
And is there any comment about the medical support device? Because it was also a very interesting topic.
What about Hong Kong? Hong Kong, I know that's in Paris, it's available.
It's very expensive instrument. We have to follow the guidelines. Low EF, maybe unprotected low EF, and maybe you need rotobation, or you work on life-dependent vessels. Otherwise, they're not going to be reimbursed by the government.
Yeah, I was very convinced by the case that were presented. It was really no, I would say no other options. Sometimes we see using assistance for so-called high-risk PCI. I'm not so convinced that it's, at least in our center, we would do it straightforward. What is your practice of assisting device, SG, for example? Not in case of cardiogenic shock, to high-risk PCI. Regular? Do you regularly use assist device for?
No. Intra-aortic balloon pump concerns. We didn't use so many as after the IVP shock 2 trial or something like that. However, recently we have some study in the patient group who had a cardiogenic shock as Ecmo support or just conventional angioplasty, and so just doing the. You're going to see that the efficacy, supportive efficacy concerns Ecmo right now.
I know Japan is only available for imperals, only criteria for cardiogenic shock.
Yes,
is that right?
That's right.
Supported for PCI.
Yeah, that's right.
High-risk
that's
PCI.
right. Oh, yeah, that's right. Only case with cardiogenic shock, we can use imperal.
So in Korea, I just mentioned that the issue is that very strict reimbursement policy, because it's very expensive device, so that for all simple high risk, even if expected to have a very high risk procedure, we cannot use prophylactically. It is not allowed, so that that's the issue we have.
Yes, and in Europe we are beginning also the Euroshock trial, a little bit what you are saying in cardiogenic shock, that add reperfusion and after reperfusion randomized, and when they are still on shock, randomized to Ecmo or not. And I think we learned a lot from that. This being said, we can close this session. Thank you to the audience. We had 2 wonderful, very educative cases of post-PCI left main restenosis, and really interesting, wonderful panel, 2 nice lectures, and I thank you all for attending this session. Thank you.